Welcome everyone to today's webinar. I'm Laura Lubbers and I'm the Chief Scientific Officer of Cure Epilepsy. And I want to thank you for joining us today. Today's webinar is entitled Non-Epileptic Seizures, Diagnosis, Treatment, and Management Strategies for Patients and Their Families. It's important to recognize that while the physical signs and symptoms of non-epileptic seizures, or NES, may be similar to epileptic seizures in some ways, people with non-epileptic seizures do not respond to anti-epileptic drugs and therefore require different treatment options. Up to 20% of those diagnosed with epilepsy actually have non-epileptic seizures. This webinar is part of Cure Epilepsy's 2021 Leaders in Research webinar series, where we highlight some of the critical research that's being done on epilepsy. Today's webinar, like all of our webinars, is being recorded for later viewing on the Cure Epilepsy website. And you can also download transcripts of all of our webinars for reading. For over 20 years, Cure Epilepsy has raised millions of dollars to fund epilepsy research that supports our mission, which is to find a cure for epilepsy by promoting and funding patient-focused research. Cure Epilepsy provides grants that support novel research projects that advance the search for cures and more effective treatments. Today's webinar will help viewers recognize the signs, symptoms, and understand the history associated with the presentation and diagnosis of non-epileptic seizures. And it will provide insights on treatment options for this condition. This webinar is presented by Dr. Kurt LaFrance, who is the Director of Neuropsychiatry and Behavioral Neurology at Rhode Island Hospital and Professor of Psychiatry and Neurology at the Warren Alpert Medical School of Brown University. He's also a staff physician at the Providence VA Medical Center and the clinical lead for the VA National Telemental Health Center Teleseizures Clinic. His research focuses on developing new biomarkers and treatments for neuropsychiatric aspects of epilepsy, traumatic brain injury, and more. Before Dr. LaFrance begins, I'd like to encourage everyone to ask questions. You may submit your questions anytime during the presentation by typing them into the Q&A tab located on your Zoom panel and then click send. I also want to thank those who submitted questions in advance of today's webinar, and we'll do our best to get through as many of those questions as we can. We do want this webinar to be as interactive and informative as possible. However, to respect everyone's privacy, we ask that you make your questions general and not specific to a loved one's epilepsy. So with that, I'd like to turn it over to Dr. LaFrance.
Thank you so much for the invitation to come and speak. It's an honor to speak to the people of Cure Epilepsy. I've known of the organization for a couple of decades. Every time I would go to the American Epilepsy Society annual meetings, I would always see a lot of buzz about what's happening with Cure Epilepsy, and am honored to be able to kind of join your group to be able to speak today. So thank you again for the invitation. These are my disclosures. I'll be talking about some of the research that we've done, but also this is a topic that for people in epilepsy, it's not a side topic, it's a main topic. And I'll tell you why. And the research that we've done over the years has been with epilepsy and non-epileptic seizures and other conditions. So hopefully what you'll come away with in kind of about a half hour of discussion is your understanding that you'll learn about psychogenic non-epileptic seizures, and you'll be able to realize that there are what we call neuropsychiatric aspects. The neurology and the psychiatry elements of epilepsy includes not just the comorbidities like depression and anxiety and cognitive issues, as many of you are familiar with, but also non-epileptic seizures. And then hopefully with understanding what they are, you can understand what can be done for them. So as a neurologist and a psychiatrist, I deal with the brain and the mind. And interestingly, it seems like it should be two sides to one coin. That's how I view the world. But not everybody does that. And sometimes in medicine, we'll split them out. This is brain and this is mind, unfortunately. Because I tell my students, our patients don't read our textbooks. So they don't divide out brain and mind. Everything comes as a whole package. So here's a couple of ways to conceptualize non-epileptic seizures. One is that it's a neurological manifestation of an underlying psychological conflict or stressor, a life event. Another way to look at it is that it's a behavioral expression of neural network dysfunction. And again, these are two sides to one coin. It's not either or, it's both and. I've had the honor of working with some wonderful colleagues and friends over the decades, and some of this is summarized in the book Gates and Rowan's Non-Epileptic Seizures that Steve Schachter and I co-edited, and much of this information is there for your review if you desire. So here's what some of the great excitement is about non-epileptic seizures, that in the past, we as clinicians couldn't definitively make the diagnosis of psychogenic non-epileptic seizures. It's also referred to as a conversion disorder seizure or a functional neurological disorder seizure or functional seizures. Those are other terms that you might hear. But now we can make the diagnosis definitively. In the past, we didn't have a treatment for patients. While there were all these great advances for epilepsy, we had nothing for non-epileptic seizures. Now we do have treatments. And lastly, we didn't understand the mechanisms for what's happening in the brain for conversion disorders and for non-epileptic seizures. And now we're gaining some insight into that. So those three major leaps, those have been major leaps forward over the past couple of decades, and I'll let you in on some of that information. So Laura's already mentioned that about 1% of the US, about 1% of the world population is diagnosed with epilepsy. Not all of those people have epilepsy. So here's a key point. Each of these slides is a way, maybe a pearl that you might be able to come away with. If you or a family member is being treated for treatment refractory epilepsy, it may not be that the anti-epileptic drug isn't working because the pill doesn't work, it's because it's not epilepsy. So up to 20% of people who are diagnosed with epilepsy actually have non-epileptic seizures. Now, I've already told you that there's a difference between epilepsy and non-epileptic seizures. Many times people keep coming back to the seizure monitoring units or to the emergency department or to the clinics saying, my seizures, they're just not responding to the 5th anti-seizure medication. And unfortunately, it's not until we get the gold standard diagnosis, which is video EEG, that they realize, well, it's because we've been treating presumed epilepsy and it's not. So interestingly, people say, well, epilepsy, there's a high level of disability, unemployment, assistance, that kind of thing. It's equal in non-epileptic seizures. And as you know, people who have seizures, what happens? They keep coming back to the emergency room and they get more tests and labs and CAT scans and EEGs and medication adjustments. Well, this lifetime cost for treating an individual with non-epileptic seizures can be up to $100,000. And then if you add that up to all of the people who have non-epileptic seizures, it can be up to $1 billion a year in the US alone. So it's a costly disorder, not only physically to the patients and family members, but also fiscally, monetarily to the individuals, families, and to our society. So I mentioned earlier, we can definitively make the diagnosis. And two of the reasons that we can is because we can use the physical exam. When you are examined by a clinician, then they will use physical signs. And using physical signs, because I was an advisor to the book that's used in psychiatry, the DSM, the 5th edition, to try and update conversion disorder, functional neurological disorder. So we made the recommendation to switch in version 4 to version 5, incorporate physical signs that we use on exam. And so now that's one of the diagnostic criteria. Also, because we have a lab, which is the video EEG, that's the other tool that we use in neurology and in epilepsy to definitively diagnose the disorder. Some people will say, well, I've heard that the person is faking it. These people who have these seizures are not faking it. And so malingering does exist. Now, malingering is about less than 5% of the people who come in to the emergency department. And those people are people who are trying to get out of prison, trying to get out of military service, trying to get on disability pay, and trying to get medicines inappropriately. That's a very small subset. So when you see somebody who's having a seizure, it may not be an epileptic seizure, but also it's not faking it. This is a real seizure, and I intentionally use the term seizure. Some people don't agree with that, but I use the term seizure because seizure, as you know, just means to be taken hold of. And so sometimes seizures are caused by abnormal brain cell firing, as in epilepsy, and sometimes they're caused by underlying psychological conflicts and stressors and life events, as in non-epileptic seizures. So having said that, when you see somebody who's having a seizure, I make the assumption this is a real seizure. Maybe it's caused by abnormal brain cell firing, or maybe it's caused by a conversion disorder, but it's a seizure. I mentioned earlier about the importance of using video EEG. There's some great data that came out a while back that said if you've got 2 seizures a week and you have 2 normal EEGs and you have failed 2 anti-seizure medications and treatment, there's an 85% positive predictive value that you actually have non-epileptic seizures. So I would call that the rule of 2s. So when somebody has that kind of story, then we say, get them in the monitoring unit. And then getting them into the monitoring unit is where some of the work that's been done across seizure or epilepsy centers, that if you give the right story with the right video EEG, with the right image, you want the video, that's the third component that's so important, then you're going to have a high level of reliability between the different reviewers of the EEGs, almost perfect, in fact, 0.94. Some people will say, well, I know that it was epilepsy because it was a grand mal and they were frothing at the mouth. And one of the things that I tell people is that any way that an epileptic seizure can present, a non-epileptic seizure can present. So just because it was generalized tonic-clonic seizure with tongue biting or incontinence doesn't necessarily, many times that's going to be epilepsy, but it doesn't necessarily mean it's going to be epilepsy. So people can have staring spells like absence, people can have generalized tonic-clonic, people can have myoclonic jerks, all kinds. That can be non-epileptic seizure just as much as it can be epileptic seizure. Another thing, and what I'm trying to do is give you some data to challenge the dogma, the learning that we have. So here's another dogma. Well, it was a head injury, so it has to be epilepsy, because you hear the term, oh, it's post-traumatic epilepsy. It happened after a head injury. A lot of people who have head injuries actually have non-epileptic seizures. So some of our studies showed that almost half of people who have non-epileptic seizures have a history of head injury, and up to 3/4 of those patients actually had mild traumatic brain injury. So realizing that this is what I call the double hit hypothesis, which is, or the double hit phenomenon, which is I had a head injury and in the car accident or in the assault or with the veterans who I see, and it was a mild traumatic brain injury. So they were awake and aware and conscious, maybe a little dazed and confused, but they were awake for the event. They had a physical hit, and they also had a psychological hit. And that's where the PTSD, the post-traumatic stress disorder, comes in. So we have to address the double hit in many of our patients with head injury and non-epileptic seizures. So some people will ask, well, we're talking about an either or, right? Well, sometimes it's both and. And what I mean by that is that 10% of patients with seizures have mixed epilepsy and non-epileptic seizures. So when you are talking to your doctor, don't just tell them about my seizure, tell them about my seizures, plural. You may have 2 different types. And there's one type where you're staring off and you're looking away and your eyes blink. But then there's the other one where your arm shakes and then it generalizes and you fall out of bed. Those are 2 different types of seizures. Make sure that your doctors know that you have 2 different types. They both may be epileptic seizures from different areas of the brain, or they could be, one is an epileptic seizure and another is a non-epileptic seizure. So that's the importance of getting people into the unit to be able to distinguish and differentiate. I'll tell people a picture is worth 1,000 words. Well, a video is worth 1,000,000 words. So if you can, use your smartphone. Not everybody can get into the monitoring unit. So start to finish, capture the video with the individual's permission, because we want to see that as clinicians. And this is some of the research that we've done with some of our colleagues to say smartphone videos can help differentiate between epileptic and non-epileptic seizures. Now, it's not the gold standard of the video EEG, but it gives us more information as clinicians to help us take care of our patients better. This really started to become, for the longest time, there was a term in the past, they used to be referred to as pseudo seizures. Pseudo, as you know, means false or fake. I've already told you these aren't fake seizures, they're real seizures. The pseudo seizures in the past were kind of dismissed in neurology, unfortunately. In the 2000s, the National Institute of Neurological Disorders and Stroke, it got on their radar because many of our patients in the monitoring units don't have epilepsy. We're calling ourselves level 4 epilepsy centers, but we don't do anything for a third to a half of the people who come into our unit. What do we do for those patients? So the benchmarks were a way that kind of allowed for the understanding of benchmark 1 basically was diagnose epilepsy. Benchmark 2 was treat epilepsy. And benchmark 3, which got added in 2007, was look at the comorbidities also, which includes non-epileptic seizures. So it's on the radar for NINDS, which is great. It's also on the radar for International League Against Epilepsy. Not everybody has access to video EEG. So when you're talking with your clinician, then you'll say, what level of certainty do we have with my diagnosis? And documented, the highest level is right history, right witnessed event, and right EEG, no epileptiform activity, abnormal brain cell firing before, during, or after the seizure. If you don't have that level, then there's clinically established and other levels, lower levels, but that's how the ILAE, it's a way that for countries that might not have access to video EEG, we can still talk about a common language of how do you make the diagnosis and what level of certainty. So we talked a lot about diagnosis. The other piece of this, I want to talk about treatment. And I mentioned earlier, now we can treat non-epileptic seizure patients with non-epileptic seizures. So a lot of advances in the past 2 decades. Here's how I organize it. The patient is at the center. A lot of times people come to us as clinicians and say, well, you're the one who's supposed to fix me. I tell them, I don't have the power to fix you. But what I can do is I can walk with you as you go on this journey. And that's kind of one of my roles as a clinician and a neurologist psychiatrist. But the patient is at the center, the individual is at the center, and then you've got a team around you. And you've got your medical team, you've got people at home, family, and then you've got your community. So I tell people, family, friends, faith, those are all part of your treatment group. And then you've also got your clinicians who are part of that team also. So to organize that, we've tried to develop treatments over the past 2 decades, and even 3, including my residency, where we've looked at, are there medications that can help? Are there therapies that can help? Are there combinations that can help? Are there other interventions? And I'll just give a brief overview of some of those treatments that we've kind of studied to let you know that there are some options out there. One of my distance mentors is Oren Davinsky, who was involved in my NINDS K23, where we really started to look at the data. And in the past, in the early 2000s, there was only expert opinion. We didn't even have controlled trials to be able to inform evidence base. And so now we've actually increased the evidence base. I'll tell you a little bit about that. So the National Institutes of Neurological Disorders and Stroke K23 that we did, the initial grant was looking at, can we do something with the medication? So what we found in a pilot trial, it's not the fully efficacy trial that you see with some of the anti-epileptic or anti-seizure medications. What we found is that using a serotonin medication, which is commonly used in depression and anxiety, there was a 45% reduction in patients who received that. And that was in contrast to people who received placebo or a sugar pill. They had an 8% increase in seizures. So that doesn't mean it cures non-epileptic seizures. What it means is it may help to reduce some. Then we also started looking at, we called it cognitive behavioral therapy. It's not cognitive behavioral therapy. I'll tell you why in a little bit. But what about a psychotherapy? And with our pilot studies, we found that a significant number of people had a full reduction in their non-epileptic seizures. So that was a big signal for us to keep going. Here's the way that we kind of organize it in our minds. Somebody had a past injury or a trauma or an incident, and then they develop the non-epileptic seizures. There are other types of manifestations also. I mentioned conversion disorder earlier, so it could be a tremor, or it could be a weakness, or it could be a walking gait disorder. All kinds of things happen after an injury or an event. It doesn't have to be immediate, like it just happened last week. It could have been remote, something from the past. And we've got data to show that things that happened years ago can actually manifest later on, even decades later. So some type of an event, life event, then seizures, then the term that we use is catastrophizing. And you're familiar with that, catastrophe. Everything is going wrong or bad. My whole life has been taken away from me. And then they fear the next seizure. I don't know where it's going to come from. This happens in epilepsy also, as you're aware. And then they start to avoid events in the world. And then they start to attend to things going on in their body so much. Oh, what's this tremor that I'm having? What's happening here? And then they get into this cycle of disuse and disability and depression. And this vicious cycle repeats itself in some of our patients. What we do with our treatment is we equip them with tools so that they can make these links between this vicious cycle. Then they use the tools to break the links. And once they've been empowered to do that, then they move out of this vicious cycle of non-epileptic seizures into this virtuous cycle of confronting their fears and moving into recovery. And it's such a beautiful thing to see patients get their lives back. So we've subjected this to kind of higher levels of evidence. We did a multi-site randomized controlled trial amongst 3 sites, and we found that the 2 therapy-containing arms, there was a significant reduction in seizures and in comorbid symptoms like depression and anxiety, and improvements in quality of life and functioning. The medication alone, which was the serotonin medication, it's an antidepressant, so it helped depression, and it also, there was a trend in seizure reduction. Here's one of the big takeaways. Standard medical care, what's delivered at the epilepsy centers around the country and around the world, showed no significant improvement in seizures or in secondary outcomes. So that was a big signal for us. We've got to do something about this, and we've got to start helping around the country. So having said that, some people would say, well, this all is great, but you're talking about non-epileptic seizures, right? No, I'm not. I'm actually talking about epilepsy and non-epileptic seizures. And here's the reason why I say that. This treatment was initially developed by Ryder and Andrews in the 80s and 90s in California for epilepsy. So you'd think, wait a minute, you're talking about a psychotherapy for epilepsy. How can you do that? Well, so what happens is their initial approach was identify your aura, use some of these behavioral interventions, and decrease the physiologic progression of the seizure. It's fascinating. It's fascinating neuropsychiatry in my mind. So I actually asked them permission to use their workbook to modify it, to make it not just taking control of your epilepsy, but taking control of your seizures. I neutralized the term so it could be used for epilepsy and for non-epileptic seizures. And because of our studies, Oxford University Press asked if they could use it in their Treatments at Work series, and they can. So it's available online. You can get it taking control of your seizures, used for epilepsy or for non-epileptic seizures. The workbook is for the patient to do, to meet with the seizure counselor, one hour a week to go over the information that the individual does. And then for those who are the clinicians, the therapist guide is used kind of from the notes of the people that I've trained in the past. We put all those together to help the people who are going to be treating the individuals with seizures. So here's what the roadmap is. If people do the treatment, there are different components. That's why I say this is not cognitive behavioral therapy. There are CBT elements to that. It's a big buzzword now, but there are also other types of therapies. And just like there are a number of different types of anti-epileptic, anti-seizure medications, there are different types of psychotherapies also. So we took the best of the different therapies, and we put them, and we targeted the known struggles that patients with seizures have. And those targets are actually equipped with tools in each of the different sessions. So it's 12 sessions. It really is to equip the individual to be able to look at life differently and to approach things on their own. So let's do that. I mentioned earlier, people around the country are trained, and whether that's in the VA system for veterans, we've trained people, or whether it's in clinicians in civilian hospitals. We've got people around the country who are now using the intervention to help with seizures. And the last thing that I'll talk about before we get ready to wrap up is one of the questions that came up with COVID was, well, people come into our office. Can you do therapy with people who are remote, who aren't in your office? The National Telemental Health Center for the VA was already around, and they had asked me in the early 2000s to take the work that we had done in civilians to help out with veterans. And in doing so, we established a tele-seizures clinic in 2012. So I've been seeing veterans all around the country, even pre-COVID, and we've been using that information to say, hey, what does it look like if you use telehealth? And what we found was that similarly, there was a similar reduction in seizures and improvement in comorbidities in people who came to the clinic or people who were seen via telehealth around the country. So it can be delivered. The point of this, the pearl out of this, is that it can be delivered in clinic in person locally, or it can be delivered remotely. So I'll close with this. Seizures has an impact on not only the individual, but on the family. And this is epileptic seizures and non-epileptic seizures. Most of our research has been comparing two different seizure types, two different seizure groups, those with epileptic seizures and those with non-epileptic seizures. So it's not just about treating the individual, it's about treating the individual in the context of their environment. And that may include family also. So when I talk about what are some of the treatment options, looking at the individual, but also looking at the social context, which includes the family, that may be of benefit not only to patients with non-epileptic seizures, but also epilepsy. I'll skip ahead because one part of the talk is on biomarkers, but we can do that at another time, only to say that we do have a study going on right now where we have patients with epilepsy and history of head injury, patients with non-epileptic seizures and history of head injury. And the third group is head injury alone and no seizures. And we're taking these three groups and we're getting fMRI before and after we administer this 12-session treatment for seizures. And we're looking at brain network changes before and after the treatment. We know that it works clinically. Now we want to see what happens physiologically and neurophysiologically. So that's a study that we're doing right now. And I will forward to, this is a way to kind of conceptualize at the end. If you're still having seizures, if you know somebody who's having seizures that are quote unquote treatment resistant or refractory, talk to your doctor and ask them, hey, do we need to look at this from another perspective? And what I mean by that is, do we need to get an inpatient video EG or a video EG, an ambulatory that you have in the outpatient setting and add in, have the video also. And then you get the proper diagnosis. Then when you have the proper diagnosis, talk to not just the individual with the seizures, but also to the family so that people understand what the diagnosis is. Then after that, you create what's called a problem list. It's not just about the seizure. To treat the whole patient, you have to look at them biologically, psychologically, socially, spiritually. You have to look at the whole person. And then you come up with a formulation and a treatment plan. And you look at things that happened in the past, predisposing factors. You looked at when the seizure started, precipitating events. And then you look at things that might still be going on, perpetuating factors. And so you address those three Ps with medications, if appropriate, anti-seizure medications for epilepsy, tapering off anti-seizure medications if you don't have epilepsy, using some other medications for depression and anxiety, which happens in epilepsy and in non-epileptic seizures, and also referring to appropriate therapy, which we talked about earlier. So there are a number of resources out there for you. We worked for almost a decade with the American Epilepsy Society to prepare the clinician information sheet. You can go on this yourself and get some information on non-epileptic seizures. It's there available for you. And to conclude, I'll just say that we didn't have a way to diagnose before, but we do. We didn't have a way to treat, but we do. And we're gaining insights into the neurophysiology, the brain workings associated with these seizures. I will say this, if you're just going to a therapist who you go and talk with them about what's going on in life, and it's kind of a kibitzing session, actually take that money and go out with a friend to Starbucks, because supportive therapy does not help this. Go for somebody who is familiar with the disorder. Go to somebody who knows that there are actually evidence-based treatments, and say, I'd like to kind of increase the efficacy of what we're doing here, they've got resources that they can look into. And finally, to wrap up, I want to thank all of the people who are collaborators and friends around the country and around the world. It takes a big team to do some of the work that we're doing, and all of this is happening because of those great relationships. So I'm very thankful. If you do have somebody who has video EEG confirmed non-epileptic seizures, or if they have epilepsy in the history of head injury, 18 to 60-year-old civilian or veteran who's interested, feel free to contact my research coordinator, and she will be able to do a screen and find out if you are interested or eligible in the study that's going on right now. And with that, I will close and open to questions.
Thank you so much, Dr. LaFrance. That was fascinating. I learned so much on this important topic, and it's so reassuring to know that there are things that can be done, because this is a real issue for people across the board. So thank you so much. We have a lot of questions, and it's been great to see them coming through, and I can help field those. If you in the audience do have additional questions, please do put them into the Q&A tab. I know some of them are also showing up in the chat, and so we will work through that as well, and we will address as many of them as we can. Again, a fascinating topic. Why don't we go ahead and start with some of the questions that came in advance, because there was a lot of activity over the last couple of weeks once people found out about this. So question, sort of a reoccurring thing is if non-epileptic seizures, it seems like epileptic seizures may come and go based on the experience of our audience. If non-epileptic seizures reoccur, are epileptic seizures also likely to reoccur? There seems to be an interest in understanding that connection, if there is one.
So when you say reoccur, I see, so we follow people over the course of time. And what we found, interestingly, is there can be periods, what we call periods of quiescence or quiet periods, where there's no seizures. This can be for epilepsy or for non-epileptic seizures. In taking the history and talking with people, we'll say, and they'll come back and they'll say, oh, I just had a flurry of seizures again. This could be epileptic or non-epileptic seizures. And the question is, anything different recently? And more times than not, what we'll hear, well, actually, I was getting ready for a final and I pulled an all-nighter. And then after the final, I had the seizures again. Again, this could be for epileptic or for non-epileptic seizures. And as you're aware, sleep deprivation is one of the ways that we actually induce seizures, whether epileptic or non-epileptic seizures. So I'll see what we'll call environmental changes. That can be after a period of a quiet period and then a flurry again, or a recurrence. Sometimes environmental, sometimes that can be physiologic changes in the person. I see this from kids to adolescents to adults. I see this with other medications being added, or bodily changes happening, all kinds of things. And then the physiology changes, and that has an effect on the way that the medications that the individual is taking is processed, what we call the pharmacokinetics and the pharmacodynamics in the system of the medication. So a few different ways that seizures might recur. Okay,
that's fascinating, because there were some questions that came in asking about whether there could be age-related from childhood to adulthood. Can that induce more non-epileptic seizures? There was also a question about whether trauma, for example, having wisdom teeth taken out, can that induce and that's a pretty big stressor in a young person's life. So it sounds like that, yes, those certainly can influence the occurrence of non-epileptic seizures.
Yes, and you said a very important word there. You said stressors in their life. So I'll hear this from some people. They'll say, but doc, I wasn't even stressed and I had the seizure. And so I'm not talking about stress-induced seizures. I'm talking about life stressors contributing to the formation. What I mean by that is sometimes it's not in the ramped up period where a lot of things are happening in life, or somebody just had a procedure or a surgery or something like that. They do happen post-operatively. I've seen them coming out of anesthesia, non-epileptic seizures, but also after procedure, like wisdom teeth extraction. But it also happens in what I call the letdown period. And what I mean by that is I'm on the beach and I'm with my family and it's wonderful. And I had a seizure there. And what's that all about, doctor? So sometimes people, when they're in the ramped up stage, they've kind of got their defenses up, and then when they're in the letdown stage, then their defenses are down, and that's where the seizure may occur. So there's not a one-to-one relationship of I was stressed out, I had a seizure. It could be in different types of environments. So I refer to life stressors, life events. We've all got life events.
Right, right, indeed. Great. I think that'll be really helpful for people to have heard. Another thing that people hear is that, well, we're not seeing an EEG signature, but it's because the seizure is occurring deep in the brain and we just can't pick it up. How would you respond to that?
I would say there are some seizures that there are some locations or foci in the brain that elude scalp EEG signal. So what I mean by that is if you've got what we call mesial temporal or some frontal lobe seizures, epileptic seizures, you can have the epileptic seizure and the EEG, scalp EEG is not going to pick up that abnormal brain cell firing, the epileptiform activity. So in that case, it's not that it's not epilepsy, it's that the focus eluded the scalp electrode. So we've got a clue there though. And so just because you have a normal EEG doesn't mean it's non-epileptic seizures. Well, we've got a clue though, and we use the term semiology, ictal semiology, and all that means is the physical characteristics of the seizure. There are certain ways that frontal lobe epileptic seizures present characteristically that differ from psychogenic non-epileptic seizures. And even though both of those might have scalp negative EEG, we can look at the ictal semiology, the physical characteristics of the seizure, and we can make a comparison. So that's why you heard me say earlier, the right history with the right witnessed seizure with the right EEG. Those are the ways that we get the documented. That's how we get documented non-epileptic seizures. If we have the seizure characteristics, even though it's a scalp negative EEG, we may say, this looks more like frontal lobe epilepsy than it does psychogenic non-epileptic seizure, just because I'm watching the seizure myself. That's the importance of the video EEG.
Oh, fascinating, fascinating, very helpful. So a number of people have asked, how do we find providers who are trained to provide these therapies in our states or regions?
There are some people who around the country, some of it is, it's an email to your local, I would say start with your local epilepsy center and say, do you have people who are trained in treatment for non-epileptic seizures? Now, that doesn't mean that they were trained with taking control of your seizures workbook. They may have their own approach. What I showed you was just one of a number of approaches. And so this is not the be all and end all for everybody. There may be places around the country who say, yeah, we've got somebody who's been treating people for 20 years and they use this approach. So I would say start with your local seizure, with your local epilepsy center, your local epileptologist. If there's a neuropsychiatry department, sometimes they'll do overlap brain and behavior, and you can contact them. Those are the main, I would say start locally. And then sometimes people will email and they'll say, do you have somebody trained in Michigan? Oh, yes. Well, there's actually, Dr. Beimer is trained in Michigan, and this person's in Stanford, and this person's. So if you're talking about treatment with the workbook, then that's how that's listed.
Okay, I think that's a great suggestion to start with the epilepsy center and move on from there. And of course, Cure Epilepsy is also helpful, willing to try to help find resources as well if we can make connections. We know that this is an area of great struggle for people and less identified providers.
Yeah.
Another question is our non-epileptic seizures ever a diagnosis that can be removed from a patient's problem list? Is this something that needs to be on the radar now and indefinitely?
So that's a great question. I view seizures, whether epileptic or non-epileptic seizures, as a chronic medical illness. And I'm thinking now of the International League Against Epilepsy's more recent definitions for epilepsy. Before, there wasn't a great definition for resolved, but now there's a category for resolved epilepsy. So just as there's a category for resolved epilepsy, you can have a category for non-epileptic seizures. That's not official from the ILAE per se, but I'm thinking kind of in parallel, what's been done for the new diagnostic criteria for epilepsy and terminology that could also be done for non-epileptic seizures. Here's what I will say. Life events are still going to keep happening. Life is going to keep happening. Somebody's going to get sick in the family. A bill's going to come due that you didn't expect. The car is going to break on the day that you don't want it. That's always going to keep happening. The treatment that the tools that patients get with the workbook, they have to keep applying those tools. The way that I demonstrate that to patients is if they have readers, then at the end of the treatment, I'll say, okay, read this sentence, and they'll read it. And I'll say, now take off your glasses and read the next sentence. And they can't read the sentence. And I'll say, the glasses didn't cure you. The glasses, you have to have the glasses on for you to be able to read. You have to keep using the tools for you to be able to address the stressors, the ongoing life stressors. So people can go for extended periods, and I've had this in people who've been in our prior studies. They've come back 2 or 3 years later, and they've said, the stuff came back. And I said, how are you doing with what's going on in life, and how are you using the tools? And they said, life has gotten a lot harder. I just had 2 kids, and I'm not using the tools. I kind of forgot about it. And so there's a little booster. And that booster is the thing that helps them to get back on track to use the tools again to address life events that are going to keep happening.
Okay, great, great. And a couple of people have asked about the role of psychogenic seizures, non-epileptic seizures, and post-traumatic stress.
Yeah.
And I think you've already touched on this a bit. It's not just the current life events that are happening, but the sequelae as well, and using these tools to address that, correct?
Yeah, so people will refer to the various comorbidities or co-occurring illnesses. And I didn't put the slide in, but you're probably already familiar. Epilepsy, we're talking about epilepsy now. Anywhere from 1/3 to 1/2 of patients with epilepsy also have depression. Anywhere from 20 to 40% of individuals with epilepsy also have anxiety. Anywhere from 1/3 to 1/2 have cognitive issues with epilepsy. So these are comorbidities, neuropsychiatric comorbidities that occur with epilepsy, very similar in non-epileptic seizures. So you've got about 1/2 of the people have comorbid depression with non-epileptic seizures, about 1/2 have anxiety, about 40% of civilians and up to 70% of veterans have PTSD, as you would expect, with non-epileptic seizures. So a lot of comorbidities. So it's not just about treating the seizure. That's why I was saying earlier, you've really got to treat the whole patient.
Right, great, thank you, thank you. So a recent question that just came in is, can there be a false diagnosis of non-epileptic seizures? Why and how?
The answer is yes, and it can go either way. You can be diagnosed with non-epileptic seizures and it can be epilepsy, or you can be diagnosed with epilepsy and it can be non-epileptic seizures. And I've seen both of those. And I've mentioned with one of my early distance mentors was Orrin Davinsky, and he said early on, Kurt, you have to approach the patient with seizures with humility because you can be fooled either way. Mm-hmm. And so people can say, oh, well, I've seen that ictal semiology. I've seen the physical characteristics of that seizure, and that's got to be a pseudo seizure, kind of they said in a dismissive manner. And you know what? It wasn't. Number one, it's not a pseudo seizure. And number two, it was actually a very odd manifestation of a frontal lobe epileptic seizure. Conversely, you can have somebody that's like, wow, that's the story for epilepsy. I'm going to treat them for 2 and 3 years with anti-seizure medications for presumed epilepsy. Nope, this was non-epileptic seizures. The AEDs are not going to help the individual.
Fascinating.
It keeps you honest, as a clinician. You can't go on saying, oh, I've got this. I wrote a textbook on it, and sometimes I'm scratching my head saying, I wonder about this. Let's take a tincture of time. Let's use a tincture of time to try and figure out. Let's see what you've got, and that's sometimes the best medicine.
Right, and really finding somebody who can work with you sounds like is important. Yeah. So here's an interesting question. They're all interesting, of course, but a different one. Do non-epileptic seizures present during sleep?
The answer is yes. The devil's in the details here. So epileptic seizures can arise out of physiologic sleep. non-epileptic seizures can occur during the nighttime when a person is sleeping. Those are two different statements. So the way that we do that is the way that we figure that out. So both of them can occur at night. Both of them can occur while people are sleeping. But what I mean by that is we look at the tracing on the EEG. And as many of the individuals know, the EEG changes when we're in sleep and out of sleep stages. And so what happens is we're watching somebody, and then there's an arousal. So they become awake out of sleep, and then they have their non-epileptic seizure. That's how we see that. But we really need the EEG that corresponds to the video to be able to say, oh, there was an arousal. And so they were awake, even though it was at nighttime when they were sleeping, and it was a non-epileptic seizure, as opposed to literally coming out of physiologic sleep and straight into a seizure. More times than not, it's going to be epilepsy.
Wow, fascinating and complicated.
Yeah, it really is.
So here's a different question as well. It's around frequency. Do you have to have regular events in order for them to be classified as non-epileptic seizures, or can the very infrequent events still be characterized as such?
I've seen people who have them once a year, and I've seen people who have 30 in a day.
Wow.
Yeah, so I wish that it was that simple. It would make my job a lot easier, but no, it's never that simple. And so we really have to pay attention to how often are these occurring, when are they occurring. In the workbook, we have a thing called a seizure log, and that's where the individual really pays attention to their symptoms. And so every day they are documenting, I had one seizure at 12 p.m., 12 noon, in the kitchen after I was preparing breakfast, and it had this effect on me. And so we get them to start paying attention, whether it's an epileptic or a non-epileptic seizure. And then when they start to pay attention to what's happening and what might be a precipitant to the seizures, then they can use some of the tools to go back and say, when I have my aura, number one, I want to get to a safe place. First thing, I want to let somebody know if I have the ability to do that. And then I want to use some of the tools that I've been learning to apply to hopefully prevent the progression of the seizure into the full-blown seizure. And we've seen people with epilepsy and with non-epileptic seizures be able to take that approach.
Wow. Wonderful. Great tool. So you talked about the workbook, and some of our audience members have brought forward other types of potential treatments. Just wanted to get your perspective on this.
Yep.
There's a project called Project Uplift.
Yes.
Is this something that's similar or different?
So Project Uplift is a great tool that's used. So that's a self-management tool that was created by the Managing Epilepsy Well Network, some of my colleagues, collaborators, who funded by the CDC, the Center for Disease Control and Prevention. And self-management so Project Uplift addresses depression and epilepsy. This addresses the seizures and the comorbidities. So it's kind of an inverse of the approach. They can both affect quality of life and improve quality of life, but the approach is a little bit different with Uplift as it is with ours. The other thing that I say with our workbook is it's not a self-help book. So it's to be done in concert with a clinician who knows how to treat people with seizures. So Uplift, you can get trained, or rather the clinician can get trained and then be able to work with individuals with epilepsy. That's where Uplift. They've got a number of other things that Managing Epilepsy Well Network uses, whether it's hopscotch, which is used for cognition or thinking problems that can be associated with epilepsy. A number of great resources that the MEWN has through the CDC.
That's a great way to explain the differentiation between those. Here's another one that somebody was asking about. So eye movement desensitization reprocessing therapy. Tell us about this.
Yeah, EMDR is what the acronym for that. People with histories of trauma can use EMDR to reduce some of their trauma-related symptoms. There are some case series that have been done for EMDR in individuals with non-epileptic seizures that showed a reduction in seizures. Those weren't controlled studies, So we can't attribute causation to say, oh, well, that's what made it go down. But what I have heard is that I've got a number of patients with trauma histories who say the EMDR was the thing that really helped me.
Okay.
Conversely, I've had people say, you know what, I started doing it and it didn't really help. So I can't, nothing that we do in medicine is 100% effective. But I can say that some of my patients have anecdotally said, this has really helped me, and some have said it did.
Okay, great. Not unlike medications. You
Same
just have to keep trying and finding those resources.
That's right.
So do these programs work for kids as well? And how do you include family members in this process?
Yep. So it has not been studied in children 18 and younger, or rather under 18. All of our clinical trials have been in 18 and older. So I'm only speaking from the published data. What I can say is anecdotally, I've had a number of people say, yeah, I used the workbook with my 16-year-old and it was fine. So when you say kids with epilepsy, are you talking about neonates? Are you talking about 18-year-olds, that kind of thing? So the way that when people ask me, hey, can it be used with kids? I say it can be used for kids who have some self-awareness and who have some maturity. For those who might be in their tweens, they might not be ready for some of the ideas or the concept. But but I've had some adolescents who were very mature and had a lot of insight. So there's not a statement about it can only be used from this age to this age. There are people who do want to do a clinical trial in kids using the workbook, but that hadn't been done yet.
Okay, great, thank you. So if there's nobody in the area in somebody's region that's an epilepsy specialist, what can they do? What can this person do? How can they find either remote resources, or is that possible? How do people, there are lots of people in rural areas or unable to get to an epilepsy center and see a specialist. What do they do?
They keep being an advocate for themselves.
Yes.
And here's what I mean by that. And I tell people, my patients and family members, you are your best advocate. I'll hear statements like, sometimes I'll say, doctor, can you write me a letter? And I say, I can, but I want you to write the letter. And I want you to write the letter to your doctor, your hospital, your congressman. I want you to write letters to the licensing boards. And the reason why I say it is because I live in two different worlds on a number of fronts. So in neurology and psychiatry, I live in two different worlds at the same time. And in the VA and in the civilian world, I live in two different worlds at the same time. Mm-hmm. So interestingly, with the VA system, being trained in telemedicine, I can treat veterans around the country. I go to my office in Providence, Rhode Island, and I see veterans all around the country because the VA is a national system. So one of the reasons that people can't treat across state lines is because for me to treat somebody in Georgia or Arizona, I have to have a license in the state of Arizona, and I'm not going to get 50 licenses to be able to do that. So that's why I'm saying lobby. Go to to the boards and say, you know what, telehealth has been helping people around the country and around the world. Let's kind of make sure that people who have specialties can treat people, or people who are primary care can treat across state lines and not have that burden of the system that exists in the civilian world. That would be a way to kind of really push the envelope, which I'm a big fan of. So that's what I would say. Keep being an advocate for yourself, but also keep asking around. A lot of times people will say, well, I've got a local clinician. They're kind of familiar. You know what, I view us in medicine as eternal students. So some people will say, I'll see you and I'll read the workbook and we'll work through this together. That's another option, is have the local people, whoever it is, to get equipped using the resources that are available. But I would say, like we talked about earlier, Epilepsy Foundation, Cure Epilepsy, American Epilepsy Society, CDC, those are all places. Sometimes you'll see websites that'll say, here are local clinicians. Keep advocating for yourself is what I would say.
Absolutely, absolutely. People with epilepsy and their families have to be strong advocates. And there are other networks. So we are aware that there's the Epilepsy Alliance is also is available in certain states, and I know that they're able to sometimes get people to visits if that's necessary and help connect to different specialists in an area. So do be reaching out if those resources are needed. And before, we just have a few more minutes, and maybe we have time for another question, but I want to let people know that once again, this is going to be posted on our website, and give us a couple of days to get the recording done and posted on our website. So if you want to view it again, please do come visit that. Also, Dr. LaFrance, people are asking for the information related to your study, and so we'll make sure that that's visible in the posting that we have. We do again have transcripts available, and we will be posting this information so people can go back to our website and review and use those resources. We'll also, again, we can post information around the Epilepsy Alliance. We try to get as many resources out there as we can. So again, this has been a fabulous presentation, a fabulous series of lots of questions, and more still coming in. Let's see if we can find one more that we can address.
While you're looking at that, I will say if people want to go to clinicaltrials.gov, they can look for epilepsy trials and also for the trial that they're asking about now. So clinicaltrials.gov, and you can type in non-epileptic seizures or LaFrance or whatever you want to do, and that'll pull up the details of the clinical trial.
Fabulous. So one last question. Are non-epileptic seizures less dangerous to the brain than epileptic seizures?
People will ask, am I going to get brain damage from these? What I will say is that the effects of recurrent epileptic seizures, and sometimes people who have certain types of epileptic seizures, they can drop their oxygen level and they can become hypoxic, and that can actually affect the brain, as you're aware. We don't see those same oxygen level drops in people who have generalized tonic-clonic non-epileptic seizures. So over time, we don't see the same brain energy risks that are associated, that may be associated with some types of epileptic seizures that we do with non-epileptic seizures.
Okay, great to know. That's very reassuring. So again, we want to thank you for your time and sharing your knowledge on this incredibly important topic. Thank you to the audience for your incredible participation, both before and during this presentation. It's been a phenomenal discussion. If you'd like to learn more about Cure Epilepsy, please go to our website. You'll also be able to review, again, this webinar and upcoming webinars. I just want to let people know that our next webinar will be on October 21st, and it will recognize SUDEP Action Day, and it will discuss the important topic of sudden unexpected death in epilepsy, or SUDEP, and cardiac function. So with that, again, I want to thank you, Dr. LaFrance, and our audience. And to everyone, please be safe.